Acute otitis media. It is an acute inflammation of the middle ear with effusion, most often caused by bacteria, sometimes with viral co-infection. The middle ear consists of the tympanic membrane and an air-filled cavity containing 3 ossicles that connect the eardrum to the inner ear. Its main function is to transmit and amplify sound vibrations, which the inner ear converts into nerve signals sent to the brain. The most common bacterial pathogens are Streptococcus pneumoniae, non-typable Haemophilus influenza, and Moraxella catarrhalis. Viruses that cause upper respiratory infections may contribute, though they are less frequent as the sole cause. Eustachian tube dysfunction, often caused by upper respiratory infections or adenoid hypertrophy, creates negative middle ear pressure, which favors reflux of nasopharyngeal bacteria into the middle ear. Otitis media is most frequent between 6 to 15 months of age, often during viral respiratory infection seasons. Risk factors include daycare attendance, exposure to tobacco smoke, gastroesophageal reflux, and lack of breastfeeding. Clinical features of otitis media are ear tugging or rubbing, otalgia, otorrhea, irritability, crying, poor feeding, and sleep disturbance. Fever is more common in infants. In infants, nonspecific signs such as loss of appetite, vomiting, or diarrhea may predominate. Otoscopy is essential for acute otitis media diagnosis. Findings may include bulging, erythematous, or opaque tympanic membrane, loss of light reflex, decreased tympanic membrane mobility, presence of air fluid levels. The differential diagnosis includes otitis media with effusion, without acute inflammatory signs, congested tympanic membrane, for example, during crying, otitis externa, for example, swimmer's ear. Acute otitis media may present complications such as tympanic membrane perforation, recurrent or chronic otitis media with effusion, conductive hearing loss, cholesteatoma, mastoiditis, brain abscess, and other intracranial infections. Management of otitis media includes the following key points. High-dose antibiotics are recommended, with amoxicillin as the first-line treatment. For children over 24 months who exhibit mild symptoms, a period of observation for 48 to 72 hours may be appropriate before starting antibiotics. Symptomatic treatment should involve analgesics and antipyretics to relieve discomfort and reduce fever. It is recommended in the prevention of acute otitis media in children to encourage prolonged breastfeeding, avoid bottle propping and bedtime bottle, reduce or eliminate pacifier use, maintain a smoke-free environment, practice good hand hygiene, limit exposure to sick contacts, particularly in daycare. Encourage vaccination, like the annual influenza vaccine and 13-valent pneumococcal conjugate vaccine. This information is provided for educational purposes only.